All right, so this is a CT angiogram with 1 arterial phase and 3 venous phases. We're going to start off with the arterial phase. We spent hours studying this. There's lots of things we're not going to talk about today, but we're going to do this, just the highlights and what we acted on today. So here we are looking at it from the front. You can see this hyoid looks crooked to you, and you can even see, just before we even get started, that the hyoid is contracted or mobilized, moved to the right. This is the carotid, carotid on the right. You can see how far away from it is from the carotid on the left. Let's remove some of those structures. And now you can see that the hyoid is stuck in between. There's a bony part of the hyoid is stuck between the internal carotid and the external carotid. And it is actually dragging the external carotid towards the midline. So here's another shot. You can see it's nowhere near the left carotid, and it's poking in between, above the carotid sinus, which is responsible for heart rate. Quickest way to shut somebody down is to put pressure right there. And we did do that in the exam today. We did ultrasound. So we're seeing the jugular vein on the right. We found a compression or something down in here. So when we compressed the jugular vein with the ultrasound to see if it was compressible, it was compressible. There's some restriction in there. That seemed to trigger a little bit, but when we came up with the ultrasound through here and then we went into here, this seems like this is what's causing the dysautonomia. This is what's going to cause you to pass out. Let's bring this down. You can see how it sticks right in there. Now this is, you're lying flat with no pillow on your back. Now here we have you turning your head to the left, and we've removed everything. There's the carotid on the right, internal and external carotid. You can see when she turns her head to the left that the hyoid clearly moves way away from the carotid. It comes out of it. And here, yeah, you can see all that clear as day. Beautiful. Oh, you can even see how it collapses. The fork wants to be close together as the normal anatomy on the left side. And then neutral, of course. And then what do you think happens when she turns her head to the right? It goes even further into the bifurcation. And you can see how it's just stabbing right in there and making them move back and separate like that. Let's get a good shot of that. All right. So that was something that jumped out at us. Look at it. Look at what it's doing there. We think that's causing a lot of your symptoms. The other thing that has to be causing some symptoms is the jugular vein compression. Let me clean that up so we can see it better. You have 2 jugular veins. They need to be draining on both sides. Some doctors think one's good enough, but that is not true. So here on the right, you can see that this styloid ligament is calcified. So this is the normal styloid process where it stops, and it appears as though the styloid ligament, and I will draw that for you. I will diagram it for you. So it started here, and it goes and attaches to this hyoid bone. So it seems as though, and there's other evidence I can show you or elsewhere in the neck, that she had a nasty whiplash or some injury in here. And this ligament, the stylohyoid ligament that goes from the hyoid horn, this horn of the hyoid to the styloid, was injured. We can see it starting to calcify through here, and I believe it's contracted and making this hyoid closer, and it's not midline anymore. So let's speak to the contractures that we found in the neck. Actually, this is the arterial phase. I think to see that, we're going to leave that and go to the venous phase, because that's where we can see that poor jugular vein being compromised by what looks like a seatbelt injury. This is we're going to minimize this and minimize this. And there's our venous. Thank you very much. Okay, so venous meaning that the contrast is now going through primarily the venous system and not the arteries. So here we can see that the jugular vein on the right seems to be dilated. Here you can see, actually we also got, hopefully I can dissect this quickly on the fly. But, okay, I'm going to. There's a seatbelt injury on the right. You can see clearly where the seatbelt is, or some sort of adhesion or something, scar tissue. Adhesion is the word we've decided on. Okay. is pulling across in here. You can see where it's digging right in there. You can see sort of a fiber is coming across there. Now, when I went in there with the ultrasound and poked on that, and this ultrasound is a sound wave going through here, which is going to irritate the autonomic nervous system. So she reacted to that. She didn't like that. And that's the way people do react when you're on an injured area. So we kind of have proof there. What else do we see? Well, we see that the clavicle on the right is not sitting anywhere near as it is on the left. Where was it when I did believe that somebody sat on you. In my notes, when you came in, I said, did anybody ever sit on you? Because it looks like it's a crush injury. And yes, somebody did sit on you at some point. So we're seeing, let me remove this so you can see better what I'm trying to, all right. So here we're seeing the first rib on both sides being pulled down. So my current work, let me move this out of the way. My current working diagnosis is that when you had that compression injury, the rib cage was pushed down, compressed, first ribs popped out of their normal location, and they're below where they should be. Let's get that a little bit better. So this first rib, you know what, I'm going to dissect that better. Let's remove the clavicle, manubrium, all these structures that are messing with us. Okay. All right, so here you can see the first rib on the right where it's sitting. You can even see that it used to sit right up in this little socket there. And you can see that it's even sitting right there below the edge there. And it's actually on both sides. And one of the reasons we care about this is that the scalene muscles attached to the first ribs, and they are very important for stability of the cervical spine. So we will, and we did not examine you we didn't do this on you today because we didn't want to provoke you. We're still trying to confirm proof of concept as to where most of your symptoms are coming from. But what we'll do with other people who are more sturdy than you, we'll put them under a load from left to right and see how the head wobbles, and it's kind of a bobblehead, and it's because a seatbelt injury on one side or the other, the scalene muscles are not able to modulate and stabilize, which is what we're expecting on both sides. So what do we want? Well, we want you to see Dr. Our good doctor that's going to do Prolo in through there, and we want him to put anything, something that will stimulate the ligaments, irritate the ligaments, and cause some contracture in there to, God willing, reduce this first rib and get it to where it's not so loose and make it to stabilize, so those muscles will modulate correctly and bring stability. And while he's there, the other thing we found is that your C2 is sitting in flexion. Again, you're lying flat on a bed with no pillow here. I don't want to go into it too much, but this joint space is open and stuck in flexion, and we're finding it that way on both sides. You can see how telescoped forward that is. So we would want prolotherapy or something to stimulate the ligaments, to tighten up the ligament structure in the cervical cranial, upper cervical spine, posterior elements there. Yeah, we have hypermobility all over the place. I think that's what I wanted to get in the video today. What questions does somebody have?
Is the top ribs affecting the jugular, or is that more the scar tissue?
Short answer is I don't know. Think of it as though there was a crush injury here. We fix things in a certain order. Adhesions in through here, yes. So today, what did we do? We pulled your hyoid back out, tried to stretch any contractures we might have, and we adjusted the atlas. We didn't even really get into the atlas. So today, we picked our battles, and we decided to adjust this atlas away from the jugular, that is being pinched on the right between the styloid process. Yeah, I know what, I didn't really speak too much about that.
So it's being pinched at the top and the bottom?
It seems, yes. It seems as though that we have the styloid that's calcified on the front of the jugular on the right, but the main thing is that the atlas is pushing through the jugular, so you're between a rock and a hard place. And let me give you a beautiful picture of that. So we have venous congestion. This jugular vein is indeed compressed, and through there's not a lot of venous congestion, venous drainage. You can see all the varicose veins, all the veins that are backed up and dilated through here. Now, when we ran the arterial phase on you, one of the first things that we noticed, and well, long story short, is that this side seemed to be inflated. One of the things we want to rule out is an AV fistula, make sure there's no, the connection between the high pressure artery and low pressure vein is not compromised, and really it shows best on the arterial phase. But it looks like this might be inflated by high pressure. So they run a catheter up there to confirm if there is an AV fistula. So we would like that to be ruled out. Today we chose to adjust the atlas, take the pressure off this jugular, open that venous drainage up a little bit better. We chose to take this hyoid and pull it forward to try to break up any adhesions in there. We're expecting, what else? We're expecting there to be adhesions through here and that we haven't really identified and understood yet. So you're asking a good question. I don't know that I can answer it very well yet. But look at the fact that the hyoid is crooked and pulled back. And we're seeing evidence of contractures throughout the anterior compartment of the cervical of the neck. Okay. Couple things in the video. She did have a 220-pound man sit on her chest. It was her brother's friend. He thought he was being funny. And she felt like he put all of his weight on her, and she felt like she was going to pop. So that was part of this crush injury that we have in here that I think is obviously causing the first ribs. And that was the other thing about the first rib. When you have a first rib that's dislocated like this, the stellate ganglion is right in front of it, and the stellate ganglion is part of the sympathetic chain, and that's going to be constantly aggravated. We've seen this with other people who have gastroparesis. You can even Google stellate ganglion and gastroparesis, and you'll see that they're experimenting with stellate ganglion blocks to shut down the sympathetic stimulus that's turning off parasympathetic or overriding parasympathetic. So, that's what we want to talk about there, the stellate ganglion. Now, before we found this here, obviously how badly it digs in there, it's ridiculous. She's going to doctors for 4.5 years, and they were talking to her in a certain way. She's a cute little 23-year-old girl. They talked to her like, your symptoms don't really make any sense. She even had one doctor put a heart monitor on her when she's lying down and say, hit the pause on the heart monitor machine. She sits up, and he says, see, your heart rate's the same. It didn't jump up. And she's like, I can see the pause on it. My Apple Watch says my beats are 153 beats a minute. I can feel it coming out of my chest. What are you talking about? So the doctor's been gaslighting her because it doesn't make any sense. Now, after we did this video, she took it to her primary doctor, who's also an emergency room doctor, and she's like, hey, I have this 3D. She's like, he says, I know 3D. He kind of poo-pooed it, but as he started looking at it, he says, oh my gosh, this explains everything. It all makes sense now. And he kind of got excited how he talked about how, that's exactly where we pushed to kind of shut you down, to bring the heart rate down that would make you pass out. And he was actually blown away. He says, we don't have this. Actually, what were his words exactly?
Yeah, he's blown away. I've never seen anything like it.
Right, and he's an emergency room doctor. So they have a version of 3D rendering that's just, I don't know, it's fast. It's what you can do fast and quick. Nothing about this is fast and quick. Oh, and the other thing is, when I said ultrasound in the video, we're using pulse wave Doppler, we're using the Clarius L7, and we're basically checking the speed of the blood flow going through there, the blood volume. That's what we tried to do, but she reacted so quickly, but we did get some good measurements in there. And it sounded, when you put the ultrasound on there, it sounds like there's a drumstick. The hyoid bone is acting like a drumstick against a drum, and it sounds like that. Of course, it's the the carotid artery that's bouncing against the drumstick, and you can hear it. Funny, weird, creepy sound. That's what I wanted to add.